It gives me great pleasure to introduce Professor Brigitte Farou, who's a professor in pulmonology, and she's head of the Pediatric and Non-Invasive Ventilation and Sleep Unit at the Necker University Hospital in Paris, France. What are the contraindications for Cpap or NIV?
So I don't like so much contraindication, because contraindication may signify that there is a risk for the patient. I would prefer to have the word non-eligible, ineligibility criteria. So it's not indicated or not possible. Why? Here you have a list of situations in which it's difficult or impossible to propose Cpap or NIV in children. First, some patients have an upper airway obstruction or an alveolar hyperventilation, which is so severe that even optimized Cpap or NIV is not able to correct or sufficiently improve obstructive sleep apnea or alveolar hyperventilation. Also, when it's impossible to protect the upper airways due to bulbar dysfunction or too copious respiratory secretions, then Cpap or NIV is not possible. Importantly, there is a family factor and a patient factor. If you have a patient with very difficult cognitive dysfunction or lack of cooperation or a non-supportive family, then it's not possible to start NIV or Cpap. Also, in the case of uncontrolled gastroesophageal reflux or severe aerophagia, however, then you can propose a Nissen anti-reflux surgical intervention and try to start Cpap or NIV after the gastric surgery. Also, there are some anatomical factors. If the child has extremely severe facial abnormalities, recent facial surgery, or complications related to the interface that you cannot resolve by changing the type of interface, then Cpap or NIV may be impossible. And also in France, we consider that if the ventilatory dependence is too high, exceeding 16, 18 hours per day, then we think it's a at-risk situation for the patient. And also it will be associated with harmful social context, because it's not optimal for the child development and social contacts and normal life to have an interface and be related to the ventilator by a nasal or facial interface more than 16 or 18 hours per day.
That's a really important point. And I come from a slightly different background where I think we probably push non-invasive ventilation for as long as possible. But I have had patients state that they do want to be liberated from the mask and that they do want to try a tracheostomy. So I think that's really important to raise that point.
Yeah, of course it has to be discussed with the patient and the family. But I think that sometimes in some selected patients, a tracheostomy can be better for the child development and social contact and life than a too high dependence on Cpap or NIV.
I also find, I think the whole family situation can be very difficult, and you don't, until you start something, realize quite all the intricate factors that are going on. Sometimes in your head you've got, this will be fine, they will be able to take it on board and do it, and they come back and see you and you realize that they've not been using the device, and you unpick out all of these things. I wondered what your thoughts were with regards to actually doing a full family assessment and patient assessment in detail, probably more than perhaps what I would have done in the past.
Yeah, so we have a good experience with a therapeutic education program in our unit where we implicate the patient and the family and we prepare them. And we have also a neuropsychologist in order to correctly analyze, optimally analyze all those factors.
It's a really, really good point.